All right, guys, so we have a long one with this module today. We are going to be covering our genitourinary system. As we know, with early development of an embryo, both of these systems start from the same primitive structure. So a lot of these conditions are going to kind of go hand in hand. There are a ton of renal abnormalities in the OB world. It's kind of just like if we remember back to the spring when we learned about renal abnormalities in adults and kids. No different when it comes to babies. So we're going to start off with some of our renal conditions, and then we'll move into the reproductive conditions. So renal agenesis, just like adults, babies can have this as well, and depending on the occurrence and the variation, it's all going to differ drastically in terms of prognosis. So this is the complete absence of one or both kidneys. Now, if we have one missing kidney, that's usually totally fine, right? A lot of people are born with only one kidney. They don't even know that they only have one kidney until they're a little bit older in life. But when we have bilateral renal agenesis, this means we don't have any functioning kidney tissue. So this is going to be known as Potter syndrome, and this is incompatible with life. So these babies will not survive. They will not survive after birth, and usually they will not even survive in utero. So something that we really want to make sure that we are confidently documenting or visualizing the absence of kidneys. Now, in addition to bilateral renal agenesis, these babies with Potter syndrome will also typically measure smaller for their dates. They are going to have some facial anomalies, so their facial structures are going to look a little bit different than a normal fetus would. And they are also going to have pulmonary hypoplasia, so their lungs are not going to be functioning as well as they should either, and that's going to come down to the fact that the kidneys are not there to produce amniotic fluid to allow for that baby to breathe. Now, on ultrasound, we are going to see severe oligohydramnios, of course, not producing any amniotic fluid, not going to see a distended bladder because they're not practicing drinking that fluid, and then we are also going to see prominent adrenal glands where those kidneys should be. So we don't want to confuse the adrenal glands for kidney tissue. We know that those are going to look very different than kidneys on ultrasound. So here we have just unilateral renal agenesis. We have the patient's right kidney. We can see that in the coronal view underneath a lot better. But then when we look in the transverse view, we are seeing one kidney here, and then we're not seeing a kidney over here. So this is our spine. Remember, our kidneys are going to sit very close to our spine. That right kidney is very prominent, and we don't see anything adjacent to it on the opposite side of that spine. Next, we have hydronephrosis. We're all familiar with this, the dilation of that renal pelvis, which occurs from a blockage of urine somewhere along that pathway of the ureter. This can occur at any location in the urinary system. So like we know with adults, we can get a blockage down distally in the ureter. We can get a blockage right up at the junction of the pelvis. This can occur unilaterally or bilaterally. This is going to be very common in male babies. Male babies have a lot of sort of kidney issues, and we'll see that as we move through the PowerPoint. And this is actually going to be the most common fetal anomaly. Hydronephrosis, especially mild hydronephrosis, is not something that we really worry about. A lot of these babies will resolve that spontaneously in utero, if not shortly after birth. We just want to make sure that we are still seeing the cyclical filling and emptying of that baby's bladder, even if they do have hydronephrosis on one or both sides. Now, a little bit milder form of that hydro is going to be our polyectasis. So this is going to be just the dilation of the renal pelvis. So this is going to be occurring up higher in that urinary system, right at the junction of the kidney and the ureter. Again, not something to be overwhelmingly concerned about, more common in male babies, and it's going to resolve spontaneously. Now, typically polyectasis is going to be like this sort of unknown cause, whereas hydronephrosis is going to have some sort of blockage occurring along that pathway. So when we don't know, when we can't really find a pathologic cause and we see a milder form of hydro, we're going to assume that that's polyectasis. On the left-hand side, this is something that we see all the time. So polyectasis, especially in male babies, you will see that little prominent pelvis of that kidney, and you'll even see the tech sort of measure that dilation just to kind of say that, hey, this is there, but we know that this is going to be normal. It's very mild. And then hydronephrosis, we see that bilaterally on the right-hand side. Pretty prominent, pretty hard to ignore. We don't want to confuse that with any sort of renal cysts. So we want to make sure that we are viewing that in sagittal, making sure that we can see that blockage extending down into the ureter. Next, we have renal ectopia. We know that this is going to be when the kidney is located somewhere other than in the flanks where they should be. We know that this is going to happen pretty early on, right? Our kidneys develop as one in our pelvis, and then by about 15, 16 weeks gestation, they should have traveled and split upward to the flanks of the patient. So this means that the kidney got stuck somewhere along that pathway. We know that when we have renal ectopia, it can also result in abnormal positioning and shape. So we can get that cross-renal ectopia, we can get those horseshoe kidneys, we can get those fusion anomalies that we know that adults can get. So anytime we have the abnormal location of a kidney, we're probably also going to run into something else going on with that kidney as well in terms of positioning or shape. So here just are two examples of what those locations can look like along that pathway. We are really not ever going to see a thoracic kidney. Usually once they're up in the flanks, they stay in the flanks. They're not really going to go up higher than that final destination, but it is possible. And then we had our pelvic kidney on the right-hand side. So continuing on with all these renal anomalies that we are already aware of, we have our UPJ obstruction, so our uretero-pelvic junction obstruction. This is going to be closer to that kidney where our ureter joins our kidney. This means that we are going to see a backup of urine into the kidney and the calyces, but we're really not going to see it down into the ureter, right? So that would be our UVJ obstruction, which we'll talk about in a second. This is going to be caused by abnormal kinks or bends in the ureter proximally. We're going to have an abnormal outlet shape, and we could have an abnormal ureter valve or adhesions. So when we have something going on in that proximal region of our ureter, if there's something going on with the outflow of our renal pelvis or the inflow of our ureter at that region, that can cause this obstruction, or if there's scar tissue or a blockage of whatever reason. This is going to be the most common reason for hydronephrosis in a fetus. As we know, hydronephrosis is extremely common in babies. Again, more common in male babies, and we usually only see this type of obstruction unilaterally, although we know that we can get hydro bilaterally. So again, we see that right kidney is really going to be affected by that UPJ obstruction, or more in that hydronephrosis categorization, whereas on our left-hand side, we're still kind of in that polyectasis dilation. Next, we have a UVJ obstruction. So this is going to be more distally through our ureter down towards our bladder. We're going to see kind of that mega ureter, that really enlarged ureter, all the way back up into the kidney. We are going to again see this more commonly in male babies and unilaterally, but we know that this is still going to produce pretty severe hydronephrosis and pretty extensive hydronephrosis because it has the entire length of the ureter to have that backup occurring in. And here we can see that distal ureter extending all the way down to that bladder and then all the way back up into that kidney. We have dilation of that ureter pretty much the entire way. We see that that renal pelvis is backing up with fluid as well. So we can assume that because we see all of that dilation in that ureter, that the blockage is going to be occurring at the UVJ junction with our bladder. Nice little diagram for you here. This should be familiar from our spring pathology class. Next, we have a ureterocele. Again, still something that we can see in adults. This is going to be the dilation near the bladder of that intravesicular segment of the distal ureter. So basically, like the soft tissue of the ureter has this outpouching, kind of like this little pimple that comes off it right as it's entering into the bladder. This is going to be commonly found in cases that have duplicating collecting systems. It can also cause hydronephrosis and bladder outlet obstruction. So it's going to have more of an effect on our bladder than a UPJ or a UVJ junction obstruction does. So here we can kind of see that distal ureter is trying to join into the bladder, and then we have this very distal segment of that ureter tissue that's like, oh, okay, I'm just going to outpouch here. Maybe there's too much pressure going on, maybe there's too much force going on from the ureter, and the bladder's not allowing that urine to come in, so it's causing this bulge outward of that distal ureter. And you can even see in this example that it is bulging into the bladder and we would expect to see the urine coming in through this little area right there. Next, we have a BOO, a bladder outlet obstruction. Again, still most common in male babies. It is going to cause bilateral hydro and dilated ureters, and this is going to be when we have a blockage at the base or the neck of the bladder. So not like a uretocele. Uretocele is an outpouching. This is going to be a blockage that happens right at that region, slightly beyond the UVJ junction. So we're not necessarily talking about an obstruction in the ureter. Now we're talking about an obstruction in the actual bladder. So a little bit more distally into that bladder is when we are going to get a bladder outlet obstruction. On ultrasound, we're going to see a distended bladder with a keyhole appearance, and we're also going to see oligohydramnios. Now you're probably thinking, well, why would we have oligohydramnios if this isn't really like talking about the function of the kidneys? Well, what happens with this is when we have a blockage in the bladder, whether it be in the bladder closer to the ureter or the bladder closer to the urethra, we're going to see this bulging and this inability of the bladder to empty that urine. So because our bladder cannot empty that urine because of the blockage in the bladder, the baby is not going to have any more amniotic fluid to continue to filter and process through. So that's how we're going to have oligohydramnios. Now in this example, most bladder outlet obstructions are going to occur in the bladder closer towards the urethra. So we're going to see the bladder filling and filling and filling and filling, and then we're not going to be allowed to empty that urine. So we get this really, really large dilated distended bladder, and then we get like this little pouching right here at the urethra that's like, I'm trying, but we're blocked. Kind of like a dilated cervix, right? Kind of spreads and thins, but it's still not allowing that urine to come out. Or if it is allowing that urine to come out, it is coming out very, very slowly and in very small amounts. Similar to a BOO, this is actually a type of BOO, a posterior urethral valve obstruction. So this is saying that the specific type of bladder blockage that is occurring in those cases are from that posterior urethral valve. So now if the valve is not working in the urethra, now we can say that that is why we have a bladder outlet obstruction. Typically, we are going to see an abnormal membrane within that posterior urethra. So it kind of like causes this extra pathway that the urine would have to go through, and it therefore blocks it. Again, more common in male babies, we're going to have a very distended bladder, a very distended urethral section that we can see, hydroureters, hydronephrosis, all of that stuff that's going to occur with more proximal backup from that blockage. And here, just kind of a general overview, we see that our urethra on the right-hand side is causing that blockage, creating a BOO, creating a backup of urine into the urethra and the kidneys. Sorry, the ureters and the kidneys. Urethra, ureters. Geez, it's hard to go back and forth between the two. So here, again, looks extremely similar to a BOO because it is a type of BOO. Just talking about what is causing that bladder outlet obstruction. Okay, so now getting into more of like the kidney conditions, we have obstructive cystic dysplasia. Now a lot of these we are going to have already covered before, so this should be a little bit of a familiar section to you, but we will have a few that we haven't talked about before. So we have obstructive cystic dysplasia. This is going to be a kidney complication that occurs when that baby has a BOO for too long. So like we said, we have all this backup of urine, baby's not really evacuating any of that urine to continue to practice breathing, to continue the kidneys functioning and practicing filtering that urine. So this is talking about the long-term effects of when you have a bladder outlet obstruction. So this on ultrasound, the kidneys are going to appear very small. They're going to become very echogenic in that cortex. We're going to see loss of that corticomedullary differentiation, and then we're going to start to see cystic replacement. So we're going to see some scattered cyst. This is now saying that our kidneys, because of this lack of amniotic fluid cycling through, because of the obstruction in the bladder, now our kidney parenchyma is not going to be able to function and practice as properly. So this is that byproduct of that BOO. So here we can kind of see more so that right kidney. We're not really evaluating the left kidney that well in this coronal view, but this right kidney, we can see we really can only see it because of the scattered cysts. But then if we look at the cortical tissue around the periphery of that kidney, it blends right in. It's like super isoechoic with all of the tissue surrounding it. So we're not really seeing that nice hypoechoic cortex and the hyperechoic sinus that we would like to see. Everything is looking the same. And if we didn't have those little scattered cysts, we wouldn't even be able to see that this patient had a kidney at all. Next, we have a neuroblastoma. Again, we know all about this. We know that this is going to be very common. It's actually the most common neonatal neoplasia, although it does have a good prognosis. It's going to be 90% of fetal neuroblastomas actually come from the adrenal glands. So you should probably remember that from our spring, that although we classify neuroblastomas as a kidney condition and as a kidney cancer, it actually starts and originates from the adrenal glands. We know that the adrenal glands sit right on top of the kidneys, so it makes sense that this cancer would develop in the kidneys, although it originated from the adrenal glands. We can see this on ultrasound in the third trimester when those kidneys start to become a little bit bigger, a little bit more prominent, and it's given this neuroblastoma time to develop. So that's when we're really going to see these masses starting to form. And then we also want to make sure that we know that congenital neuroblastoma is going to be diagnosed within 1 month postpartum. So sometimes, although we can visualize these in the third trimester, we're not able to evaluate them or give a diagnosis because most women, most normal low-risk pregnancies are not getting a third trimester ultrasound. They're only getting a first trimester ultrasound, a nuchal translucency, and an anatomy scan early on in that second trimester. So we're usually not going to diagnose these until the baby's already born, and then that's when we coin the term congenital neuroblastoma. And here we can see that mass sitting right in the fossa of where the kidney would be. We have our transverse spine right here. So we know that that is going to be a typical location for neuroblastoma. Next, we have infantile polycystic kidney disease. So we're coming back to all of those polycystic kidney diseases with all of the acronyms and all of the confusing letters. Now remember, infantile polycystic kidney disease is an autosomal recessive condition. So your boards are going to coin it as ARPKD, autosomal recessive polycystic kidney disease. When you see ARPKD, you kind of automatically assume adult, right, polycystic kidney disease, but that's not what that stands for. Autosomal recessive polycystic kidney disease is the infantile version of this condition. So it has a disorder, it has a prevalence of 25% recurrence. I'm not a huge genetic person. I don't really understand what that means. Like if your grandparents have it, then you have it. If both of your parents have it, then you have a 50. I have no idea. So 25% recurrence rate in terms of your genetic family history. It is a recessive, so those usually will skip. Usually your parents will carry the gene and then give it to you. But again, do not quote me on genetic information. These conditions are going to have cysts that cause enlargement of the kidney while compressing the functional renal parenchyma. So again, that's going to have an effect on how well that kidney functions because you have these cysts that are really big and they're compressing that tissue, making it harder for that tissue to function properly. We can diagnose this in utero, but this is typically going to be a genetic testing type of diagnosis that's going to be confirmed with blood work. It can affect mainly the kidneys, but also the liver. On ultrasound, the most severe cases of this are going to present with oligohydramnios and absence of the bladder. And that's saying that this baby has so many cysts that are so large, it's really affecting that functional kidney tissue to the point where it's not working anymore. We're not producing any amniotic fluid. We have oligohydramnios in our sac, and then we also have nothing in our bladder. So we know that there's really no amniotic fluid being produced, that this baby is practicing and filtering through. We can also see enlarged kidneys depending on how big those cysts are. They're going to be homogeneously hyperechoic, so they're not going to represent that normal differentiation between the cortex and the medullary tissue. We're not going to see that hypoechoic cortex. So everything is going to be kind of isoechoic, hyperechoic, than what we would typically expect to see. We're going to see an abnormally small bladder, as we know, not producing as much amniotic fluid. lost that corticomedullary differentiation, and they can appear normal earlier on in pregnancy. So again, if you're not going for a third trimester ultrasound where we can really kind of see prominent kidneys, then this may be hard for us to diagnose on ultrasound. This is something that we are going to rely on genetic testing for, because the kidneys are going to appear normal earlier on in that pregnancy. So if you're going in for your anatomy scan at 18 weeks, we're not really going to be able to definitively see that your kidneys look abnormal. So continuing on with the infantile polycystic kidney disease, there are different classifications to this. I believe we went over this in the spring as well. Depending on the occurrence, depending on the variations, depending on the time frame of when the diagnosis of this is happening, this is all going to have different prognosis. So juvenile infantile polycystic kidney disease is going to be a little bit less severe than, say, a neonatal occurrence or infantile occurrence. This means that your kidneys have maybe functioned for a little bit longer, and they're not really responding as much to that recessive disorder, and it's not really affecting the kidney function as much as it would if you were, say, a neonate, where you're, a month old and you are suspected to die within the first year of life. So depending on severity, variation, genetic occurrence, age, time frame, all is going to have different types of prognosis. So here we have an OB ultrasound on the left-hand side and then a PD ultrasound on the right-hand side. So if you're probably wondering why that kidney on the right-hand side looks absolutely massive, that's because we're scanning them as a PD patient now. So on the left-hand side, we see that that kidney is massive in utero, right? Here's the baby's thoracic cavity. Here's the baby's abdominal cavity. And our kidney is occupying all of that space. But it's homogeneous, it's really hyperechoic, right? So it's really not the normal appearance of a kidney that we would expect to see in a baby. And then same thing with a PD patient. We would never want to see a kidney looking like this. Super enlarged, super bulky, hyperechoic, kind of smooth in its appearance, don't have that normal cortex versus medullary section at all. Moving on to adult polycystic kidney disease. This is a little less concerning than infantile polycystic kidney disease. This is an autosomal dominant condition. So usually it's a very strong family history of polycystic kidneys. It also in babies can be associated with Beckwith-Wiedemann syndrome. So now we coin the two terms or the two conditions, infantile and adult polycystic kidney disease. Infantile we know is autosomal recessive. Adult is autosomal dominant. Just because we coin an autosomal dominant condition, an adult polycystic kidney disease, does not mean that you cannot have that from when you are a baby. You literally will have this from when you are a baby. So we try to keep it to autosomal recessive polycystic kidney disease and autosomal dominant polycystic kidney disease, because you're both going to be diagnosed with this from a very, very young age. This is what you are pretty much, you are born with this. This is your genetics either way. Now, depending on which one you have, the better the prognosis, right? Autosomal recessive polycystic kidney disease, not really that good. Okay, autosomal dominant, these people go ahead and go on to live very normal lives. They a lot of times don't even know that they have this condition until they're a lot older. On ultrasound, we're going to see enlarged echogenic kidneys, and in the fetal aspect of adult polycystic kidney disease, we're usually not seeing any cysts. So those cysts are going to develop over time as those patients get older. So when we're looking on ultrasound, on the right-hand side, this is what we're used to seeing when we're scanning an adult renal patient. Normal appearance of polycystic kidney disease in terms of autosomal dominant. Now, when we're looking at them prenatally, when we're looking at them in utero, we kind of just see those really prominent, really bulky kidneys. Now, look at those kidneys there for the baby on the left-hand side. And then look at this kidney here on the left-hand side as well. They literally look the same. right? So we're not going to be able to tell in the ultrasound world which type of polycystic kidney disease a baby has. Is it autosomal recessive? Is it all autosomal dominant? They're just going to look like this. They're going to be enlarged. They're going to be hyperechoic. They're going to be homogeneous. We're going to have lost that cortical medullary differentiation. Our responsibility is to make sure that we are documenting those kidneys properly so that the patient can follow up with whatever testing that they need to do. Next, we have multicystic dysplastic kidney disease. We did talk about this in the spring. This is going to be when we have multiple smooth, non-functioning, non-communicating cysts of variable size and number. These cysts are going to replace the kidney tissue. So unlike polycystic kidney disease where it compresses the tissue, this is going to replace them. And also the cystic obstructive dysplasia where it just compresses the tissue. This is going to replace the tissue. So we're going to have a total lack of renal parenchyma, non-functioning kidneys. We hope to see this only unilaterally, but it can occur bilaterally, and if it does, it has a similar prognosis to bilateral renal agenesis. It's basically saying you don't have any normal functioning kidney tissue, therefore it is incompatible with life, so it is lethal and deadly. It can also only occur in a portion of a kidney as well, so that's kind of best case scenario. If it only occurs in one portion of one kidney, you're like, all right, cool, I have 1.5 kidneys left. So this is what this is going to look like. Unfortunately, this is not going to be compatible with life because it is occurring in both kidneys. Now remember, don't be confused with polycystic kidney disease with this, because we're not going to see cysts in utero of a polycystic kidney disease baby. Okay, next we have Prune belly syndrome, and I put this one in with the genitourinary because it has a very big effect on the urinary system, although it can kind of cross over into the abdominal system as well, because it mainly is an effect of the abdominal wall. So this is going to be a congenital condition where babies just do not develop abdominal wall muscles, and it gives them this kind of prune belly appearance. It's super wrinkly. There's no protective structure to this baby's belly. There are 3 features that go with prune belly syndrome. We have cryptorchidism, so we know that this is only going to occur in male babies. We have agenesis or hypoplasia of the abdominal wall muscle to the extent where we have no really supporting structures of the abdominal wall. And then we have dilation of the collecting system. So it's really going to have an effect on those kidneys. This results from an embryologic defect. So as that baby was growing from the primitive germ cell layers, so the mesoderm, the ectoderm, all of those derm layers and those germ layers that our systems are supposed to develop from, something along that development caused this lack of an abdominal wall to form, and also had an effect on our kidneys and our genitalia system, so on our reproductive system. So this is what these babies are going to look like. You can see there is no supportive structures of that baby's belly. Everything is sort of kind of just like flattened out to the side. You can also look down in their pelvis. This male baby has abnormal male genitalia. We can assume that he also has cryptorchidism, the undescended testicles, and this is going to have an overall effect on that kidney system as well. Next, we have a urachal cyst. So we have talked about this as well. The urachus is a very primitive structure that connects our umbilical cord to our bladder. Now, typically, this is going to be something that goes away right before birth, but in a lot of people, it stays. So a lot of people have a urachus that just kind of stays there dormant and nothing really happens to it. But also some of those adults can go ahead and get like abscesses that form over time, or these cysts that form over time. So it can happen at any age, but it's not going to happen to everyone. It's not possible to happen in everyone because not everybody still has a primitive urachus. Most of the population, it's going to go away. But if you do happen to have it, you can get these cysts that develop at any age. It is going to be more common in older children and adults. So we're not going to see this in a newborn baby. We're not going to see this in a very young PD patient. This is going to be more so in that adolescent and adult age. I remember I scanned a guy who was like I think like in his mid 50s, and he kept getting this belly button infection and nobody could figure out why. And he was like a construction worker, so like he thought it was just like him being dirty, or like, you know, putting like a lot of wear and tear on his abdomen from his job. And when I tell you guys that his belly button smelled so bad, it was one of the worst smells I've ever smelled in my entire life. We ended up finding that he had a urachal abscess. And then they went in and they surgically removed the whole thing, and he was totally fine after that. So here on ultrasound, we have our little belly button indentation right here. You can see that this patient still has a urachus. It's going all the way down towards their bladder. And then we have this prominent section here for our cyst. Okay, moving into our reproductive system. Again, like we know, a lot of these conditions are going to be very prominent in male babies. So that's what we're going to spend a lot of time talking about, but we will kind of talk a little bit about some female reproductive conditions as well. First one is hypospadias. So this is a birth defect, and this is only going to occur on male babies. This is when the opening of their urethra is actually located underneath the penis, regardless of like positioning. So the urethra opens at the end of the penile tissue. Hypospadias is when you lift up the penis, it's going to come out underneath, like the, would it be the dorsal side of the penis. This is going to give us a tulip sign on ultrasound. If you guys have ever watched Dave on, is it Hulu or HBO? He literally talks about having this condition, and when he was a child, he had to have like so many surgeries to have this opening fixed, and it like traumatized him, and that's like what a lot of his, like he actually jokes about it in a lot of his music, but this is what that condition actually is. So if you're trying to visualize what that looks like, look at the diagram on the right hand side. This is going to be us looking up underneath the penile shaft. So typically you're going to see the urethra opening here. Now, regardless of like if the patient is circumcised or not, like this is not going to have an effect on that. It would be something that they would have to evaluate prior to giving the baby a circumcision. Like you would want to make sure that the baby doesn't have hypospadias before they go ahead and circumcise the baby, because then you could like surgically place the tissue over the opening, and then you have like a way worse scenario on your hands. But if you're looking at this one right here, this is typically what's going to happen. So kind of close towards like the end of the penile shaft, but it's not coming out of like the actual region where it should. And then this one is going to be periscrotal. So this is coming off from like the junction of the penile shaft and the scrotal tissue. So I've never seen a case periscrotal. They're typically going to be like right underneath where the distal end of the penile tissue is, but I've never seen a periscrotal, but it can happen. So anywhere along that penile tissue is where your urethra can open out. And then on ultrasound, this is going to make our job a little bit harder when we're trying to confirm gender, because you don't want to confuse the tulip sign with the hamburger sign of the female genitalia. So if you're looking on the left-hand side and you see this, your brain is going to jump to being like, oh, that's a female baby. But look at your surrounding structures. You have scrotal tissue that's looking at you here. You have scrotal tissue that's looking at you here. So the way that you are scanning through and sweeping through that scrotum and the penile tissue is going to be how you can evaluate where the opening is. So we're literally just looking at this tiny little opening right there. You don't want to miss that. Same thing on this right-hand side. Right here. But this is a little bit easier, a little, I guess you could say, harder for you to be confused about in terms of confusing for gender. Next, we can also have hydroceles, as we know that this is going to be an excessive accumulation of fluid surrounding the testicles, so in the scrotal sac. It's going to result from communication with the peritoneal cavity. So this fluid from the peritoneal cavity kind of just gets stuck down in that scrotal tissue. On ultrasound, we're typically going to see these bilaterally in the baby's scrotum, but we can see it on one side. It can be simple or complex. And this is our little owl sign. So the testicles almost look like they're free floating throughout that hydrocele fluid. Also, very enlarged scrotum as well. We're typically not seeing the testicles within the scrotum. The only reason that we are seeing the testicles within the scrotum is because we have the fluid that's surrounding them. Cryptorchidism, this is undescended testicles. The testicles are going to remain up in the patient's pelvis in the inguinal canal until 28 weeks gestation. Right before birth, they are going to drop down into the scrotal sac. If they don't, this is when we have cryptorchidism. So a lot of babies are born with the testicles still up in their inguinal canal, and that's really concerning because our testicles are supposed to be located outside of our body for heat purposes. So we're going to have a higher risk of cancer because of that, a higher risk of infertility because of that, and a higher risk of torsion because they're kind of just free floating in that inguinal canal. When they're down in the scrotum provides kind of like a snug structure to keep those testicles sort of in place. On ultrasound, when we're looking within the scrotal sac, we're not going to be able to visualize any testicular tissue, although I just said that we're not really evaluating any testicular tissue in the scrotal sac anyway. So this is something that they're going to diagnose right after that baby is born. When you have a male baby, they come in, they check that right away. It's something that they palpate to confirm. And then if they have any questions about that, then they can do a pediatric scrotal ultrasound after the fact. So here's an MRI. We are looking on the left-hand side, kind of like a cross-section up the baby's bum. And we can see that we have our bladder right here, and our scrotum is located at the same level as our bladder. So that means that our scrotum is located really high, which we don't want. And then once they drop down into the scrotum, we can see that we're kind of coming through the thigh tissue here, soft tissue, and the scrotum sitting nicely between that thigh tissue, lower outside of that level of the bladder. Next, we have ambiguous genitalia. So this is kind of like a general term coined to we cannot tell gender of the baby. This is not because the baby's legs are crossed or the baby's not in a good position or the baby's being shy. This is because we can see the genitalia, but we don't know what it is. So it looks a little bit like it could be both. Now, there is such a thing as true hermaphroditism, and this is when babies have both ovarian and testicular tissue present. This is not something that we are going to be able to confidently confirm on ultrasound. This is something that's going to be done through genetic testing. So in order to say this baby has ovarian and testicular tissue, that is only going to be confirmed through some sort of blood work or amniocentesis. When that is the case, when we have true hermaphroditism, the baby has both types of reproductive tissue, it's going to be associated with other chromosomal abnormalities. So that's not going to really be the only thing that's going on. On ultrasound, it's extremely difficult for us to confirm that. And we also have to make sure that we are not confusing penile tissue from enlarged clitoral tissue. So if you think about the amount of hormones that are in the baby, when you have a female baby, the female reproductive tissue is going to respond drastically to all of the estrogen and progesterone that's cycling through the mom, right? So that's going to make everything on the female baby a little bit larger. Now on the male baby's anatomy and tissue is going to be responding to estrogen and progesterone. So if you think about a guy who takes like steroids, it makes all of his reproductive tissue much smaller. So we're going to typically see smaller penile tissue or smaller male tissue and then larger female tissue. But sometimes because of that, one can look like the other. So here we have two examples of true hermaphroditism. So it's a little bit more obvious on the right-hand side because you're seeing a rounded scrotum, and then you're also seeing the three-line sign or the hamburger sign of the labia. On the left-hand side, you're kind of like, okay, I'm not really seeing a penile shaft. I'm not really seeing a prominent rounded scrotum. I'm not really seeing a 3-line sign. So we're not really seeing any confirmation of either gender. So these are going to be both cases of hermaphroditism or assumed hermaphroditism that would definitely warrant some type of genetic testing. Okay, moving into some of our female conditions. We should remember these from our GYN class over the summer. We have Hydrometrocolpos. This is talking about an accumulation of fluid in specific sections of the female anatomy. So is it in the uterus? Is it in the vagina? Colpus is going to be vaginal. Metro is going to be the uterus. I feel like I just said that wrong. Hold on. Yes, okay, I said that right. I just needed to confirm because sometimes my brain is like, no, you just said that wrong. So this is when we are going to see this back of a fluid for some sort of atresia distally in that female reproductive tract. So we're going to have either vaginal or cervical atresia. We could have an imperforate hymen. So we have a membrane that kind of covers that vaginal canal. And then on ultrasound, we are going to see hypoechoic cyst-like fluid in that region posterior to the bladder where the female anatomy is going to be. Now, we don't routinely evaluate the uterus or the ovaries on a female baby. So this is something that's definitely going to be confirmed when the baby is a PD patient. So after birth, in the first few months or a year of life, we could go in and kind of see pediatrically what's going on. So on the left-hand side, these are PD images. You can see the really distended vaginal canal here. Not really so much going on up in the uterus. So this is definitely going to be like a hydrocolpos sort of condition going on. And then same thing down in the bottom picture. Definitely occurring up in the uterus, little cervix, and then collecting in the vaginal canal as well. And then here on this OB picture, we see the bladder right here. Umbilical arteries going around it. Nice, pretty wide picture that we love. Spine right here, and then we see accumulation, cyst-like fluid, cyst-like mass in that region posterior to the bladder. We also can get fetal ovarian cysts, and this is going to be from those maternal hormones. So the baby, the female anatomy is responding to that really high level of estrogen and progesterone. So it's going to kind of create these cysts. They are going to actually be normal functional cysts. So throughout the pregnancy, throughout the gestation, they can come and go. They're going to typically go away completely before birth, although it can have some side effects to the kidneys, to the ovaries if they do not regress. So they can lead to rupture, torsion, intestinal obstruction, depending on how large they get. And it's actually the most common cystic mass in female fetuses. So here we can see our normal ovary on a female baby. Again, not routinely evaluating the ovaries on a female fetus. But we have our bladder right here and our chocolate chip cookie ovary sitting right adjacent to it. And then here we got this big old guy. So it's really important because you could look at that and say, well, how do I know that that's not unilateral multicystic dysplastic kidney, right? You don't know that unless you are scanning and you know that you are in the level of the pelvis. Use your bladder as a window. Use your spine to help you figure out where you are in terms of like clockwise rotation. So just make sure that you are using your context clues to help you figure out which section of the baby's anatomy you're actually looking in, because a lot of these conditions can be confusing because babies are so small and the levels are also closely related to each other. So any questions, please feel free to reach out to me. A lot of this stuff should be at least familiar from the spring. A lot of these terms should be familiar. So any questions, do not